Request Dr. Rajiv Raman now to please speak on artifacts in OCTA. Sir has been as a senior vitreoretinal surgeon at Shankar Nethralaya. He was also head of research in the diabetic retinopathy project, which I was also a part of in Shankar Nethralaya during my fellowship. He is a wonderful teacher, and his presentations are among the best that I have seen in terms of PowerPoint. Welcome, sir.
Thanks, Chekitan. And I think the order is a little odd. This was supposed to be first, and then on that preface we start talking about disease. But it's an important topic to understand what artifacts we see on OCT. And as we were discussing, structural OCT is something we cannot manage without today in a retina practice, or structural OCT, still the workhorse. And OCTA is more as an adjuvant in the management of many of the retinal diseases. So it has not yet come to this side that it's very much important. But yes, in next couple of years, we may see that happening. So as we know, it is OCT angiography. So it helps us to understand the vascular pathologies. Now, what vascular pathologies? The location of vascular pathology may be a CNVM, a new vessel, a dropout of the vessel. So we can know the location, the extent, the morphology, any void areas which are present. We also get a quantitative measurement, that what is the vessel density actually, and the areas of non-perfusion, including the FAZ, the foveolar vascular zone. And this was a very nice study which was done by Wisconsin Reading Center. They wanted to know what is the prevalence, how common are these artifacts. And to my surprise, only 11 of 406 had no artifacts. That means 98% images of a OCTA will have some form of artifact. So it's important to identify, or at least to know, that these are the artifacts which can be present, and most common being the eye movement and then defocus. I'll be just sharing some of them. And why there are artifacts? Because OCTA actually attempts to derive information from movement. So wherever there is a movement, it can be misinterpreted as a flow because of cardiac cycle, because of breathing, because of tremors, microsaccades. All of them will cause movement, and all of them can cause artifacts. So that's the reason artifacts are common. So the artifacts can be related to the patient, it can be related to the software or the operator. Now coming to the patient related one, the most common is because of the movement of the eye and the blink artifacts. So if you see the top one, this is the normal scan, and once the patient moves, you can see the B scans which are going, suddenly there will be a disruption, and you can see this type of a cut or a disruption of the layers which you will see. It's called as the blink line. So if you see carefully, you can see suddenly there is a disruption, that's a blink line. That is one of the artifact, very common artifact. Even if you look at all the images which were shown before, many of them have these blink lines. It doesn't matter till you are looking at qualitative. For presence of NV, even if there is a blink line, it doesn't matter at all. But if you are trying to measure the vessel densities, this will definitely matter. It will not give a correct reading. This is a larger blink in between, or it's probably closing the eye in between. You'll get this type of artifact. Then there is shadowing effect. Now this again, so if you look at the structural scan on the left side, you can see a little shadowing in the left corner, and that actually reflects, not very clearly seen there, but you can see it by screen in the lower left corner. There is some shadowing. It gives the appearance that there is some dropout of vessels, but actually there is no dropout. So it's important to know this shadowing. And here, so you have the vitreous opacity causing a shadowing. So that's again, so there is no capillary dropout here. It is the shadowing which is causing. So it's important to recognize these artifacts. It can be a software related artifacts, and usually the softwares are there to compensate on the movement artifacts. So whenever there is lid movement or blink or eye movement, there are softwares which are built in which try to compensate. But the problem is these induce their own artifacts. And these are the artifacts which are caused by the software, the doubling of vessel, stretch artifacts. So you can see this is doubling of vessel. That's a software related artifact. It's not because of patient. Or if you see the corner, that white, there is some stretching which is happening. That's a stretch artifact. Again, because of the software. Or a crisscross artifact, because the software is trying to remove the artifacts which are caused by the movement. This is a more common one. So this, if you look at, this is a crisscross. You can see many of these artifacts which are because of software, not because of the patient movement. Again, important to identify, because if seen this image, if you show this image, they will see exactly what has happened. There's so much of vascular pathology, but actually there is no vascular pathology. It's the artifact. And it's not only on the superficial, even on the deep, you can see FAZ. Somebody has to look at only the FAZ and comment that FAZ is normal or not. If they don't know that there is an artifact, that's a problem. Or it can be an operator related one, like he has taken decentration. The image is not centered. And these images, if you try to use the measurements, they will all be incorrect. So decentration or a defocus. It's not focused properly. Again, you will not get a proper image. So besides these, there are two common artifacts which are seen with OCTA, the segmentation errors and the projection artifacts. So segmentation, each machine has got an automated segmentation algorithm which provides all the layers, retinal and choroidal layers, and they can differentiate various layers of the retina, and they all have been made, actually developed using a healthy eye, imaging the healthy eye. But we know when there is pathology, there are cystic spaces, there is thickening, there is some membrane, there is SHREM, all these, the segmentation will change, and that will not give a correct idea about the disease. So they will get altered. The boundaries between the various anatomical layers will get altered in these diseases. So segmentation will not be correct. So if you look at this example, this is one of the patient having this segmentation problem. So in this, you cannot make out that there is any clear membrane. The moment you make a segmentation more clear, you can see the membrane. So if the segmentation was wrong, you would have missed a CNVM, which you can easily pick up if the segmentation becomes correct. The same is true which he was mentioning about NVEs. You cannot, because NVE you need to be having on the vitreoretinal surface. If you miss it a bit, if segmentation is not proper, you will miss identifying those new vessels. And one of the way of identifying that there is a correct segmentation or not is to see the video. So many times the machine is in a different room, you are in a different room, and that doesn't happen. But it's ideal that you see the video, go through all the slabs, and you will identify if any membrane or segmentation error is there. So it is one of the best method to not to miss any of the lesions. The other artifact which happens is called as a projection artifact. So the light which arrives to the retinal pigment epithelium is also influenced by some flow which is happening above it. Okay, and this is again universally present in all OCTAs, and there are algorithms to remove these projections. So I'll explain it with this example. So you can identify a flow, you can identify the capillaries or the blood flow in the superficial layer. So this glass slide is there and there is some fluid on that. You can see a shadow happening down, that is projection. So you can see the projection. So if you see here, there is projection of water on the lower level, that is projection. The same way in the retina, the superficial capillary plexus vessels, the blood is flowing, that casts a shadow or projection on the deeper layers, on the retinal pigment epithelium. And that is an artifact. You don't want that artifact. Why you don't want? Because it can really create problem. Now, if you look at this scan on NFAS, it's actually, it looks like there is a CNVM there. If you see the structural B scan, it's actually the area of atrophy. So there is area of atrophy, and the superficial vessels are casting the shadow there, giving an appearance of a CNVM. And that can be so misleading. You will immediately see there is network of vessel and you may inject, but there is no vessel there. So it's the easiest way is to compare it with B-scan when you want to really know whether there is any projection artifact or not. And on B-scan, if you can see down, it appears as a tail, the bright shadows which are coming tail arising from the retinal pigment epithelium, that white color lesions. And there are software. So this is with the SSOCTA, they have this projection. So this is off projections, and you make it on. So the projection removal, artifact removal software gets activated and you can remove it. Wide field OCTA has its own challenges. There are own artifacts which can be produced because of more acquisition time. You get more of motion artifacts. Peripheral region may get defocused, out of focus, and as I was mentioning, even if you use some methods to enhance the view, like using 20D, the peripheral area which gets enhanced is usually defocused. Alignment errors may be there, especially the superior and inferior half. And what you don't see with a routine OCT, eyelash artifact, what you see with optos, can also be seen with SSOCTA. So they have their unique artifacts. It's important to know that these artifacts do exist, and the way you should do a OCTA interpretation is image the right spot, what you want to actually see, then look at the ENFAS OCTA image, look at the segmentation lines, whether their segmentation has been done correctly, look at the B-scan with the fluid the flow overlay, and then finally look at the intensity map so that there is no shadowing. So how to minimize the artifact? It's important to have good patient preparation, instructions to the patient, seating, fixation target, good pupillary dilatation, and B-scan should be followed. Immediately you should review the B-scan and compare whether what you have taken images are correct or not. And most important is you must know that these artifacts do exist, because I can see only what the mind knows. So if you don't know about these artifacts, you will never try to look for them or minimize them. Thank you very much.
Thank you, sir, for a wonderful presentation, as always. And I think that is what is important. You cannot absolutely depend on OCTA to make a diagnosis. It can be the third investigation, I would say. You do a OCT, you do a FFA or ICG, whatever you want. And then if you're still confused, you do that. And of course, for follow-ups, like especially in ARMD, you do a follow-up of the CNVM, you see the regression and all those things you can pick up. So it is a adjunct, I would say, as of now. But soon, I think there will be softwares and things and more research which will make it more useful. Any questions for sir?